welcome to EHA Unplugged, the official podcast channel of the European Hematology Association, EHA.
Hello, I am Isabel Olivera, a medical writer for EHA. Welcome to our podcast exploring the recent gene therapies approved for sickle cell disease and transfusion-dependent beta-thalassemia. Today, we are thrilled to have here Dr. Stefano Rivella, a hematologist and research faculty member in the Division of Hematology at Children's Hospital in Philadelphia. Welcome, Dr. Rivella.
Thank you so much for inviting me. It's an honor for me to address these questions about gene therapy. I'm Stefano Rivella. I was born in Italy, moved to the United States when I started my postdoctoral work. I was always very interested in doing gene therapy because during my work in Italy, I was basically cloning genes and tried to identify genes that were associated with mutation, etc. But I thought the future of medicine was going to be use this information to cure patients. So I moved to the United States. I started working on gene therapy when a lot of people didn't think it was an interesting topic. And now it's history. We have a lot of products that we can discuss about and patients have been treated with these novel technologies.
Thank you for being with us today. So we want to explore in this podcast how these recent gene therapies for sickle cell disease and beta-thalassemia work, their clinical safety and efficacy, and how widespread their use is or will be. So let's start by the basics. What gene is there to repair? What I mean is, what is the molecular defect in sickle cell disease and in beta-thalassemia?
Sure. So beta-thalassemia and sickle cell anemia are basically sister diseases in the sense that in sickle cell anemia, we have a single mutation in the gene called beta globin, and this mutation basically modifies the structure of the protein, which is an important element to make hemoglobin. So hemoglobin is oxygen carrier molecule that presents all our red cells, and without that, we don't transfer oxygen from the lung to the many cells in our organs. And so the sickle cell mutation modified the structure of the beta globin gene. In beta thalassemia, the gene is the same. The mutation are, however, different in the sense that all the mutations associated with beta thalassemia decrease the expression of the beta globin protein. So in other words, again, looking at hemoglobin, which is the oxygen carrier molecule, is made of primarily by two proteins. One is called beta, one is called alpha. And so in beta thalassemia, we have a reduction, so few beta globin proteins and an excess of alpha globin proteins. And this unbalance is responsible for the toxicity of the cells. Red cells don't cope well with this excess of alpha chains, and they die. They don't differentiate well. They expand in the bone marrow and the spleen of the patients, and the patient in both cases, sickle cell and thalassemia, many times patients require blood transfusion. Like every 2-3 weeks, they need to get blood from donors because they don't make red cells or they make bad red cells. And so they need donor red cells to survive.
So there are two gene therapies that have been approved by FDA for sickle cell disease and for sickle cell disease. So Lyfgenia and Casgevy.
Correct.
Casgevy is also approved for transfusion-dependent beta-thalassemia.
Correct.
And then in Europe, only Casgevy is approved. Yes, is the situation? Yes.
Yes, yeah.
They work in different ways, Lyfgenia and Casgevy.
Yes.
Can you explain briefly how Lyfgenia works?
Absolutely. So the two products are different in the sense that Lyfgenia works is considered a technology called gene addition or gene complementation. So what does it mean? It means that a patient has a mutation in the beta globin gene, could be sickle cell or thalassemia, and gene complementation or gene addition means basically they introduce in the stem cells, hematopoietic stem cells of this patient, an additional copy of the gene that, in this case, that doesn't have mutation, and so would compensate for the lack of production or dilute the sickle cell protein production in the stems in the erythroid cells deriving from the stem cells of the patient. So in order to achieve this gene addition, you need to use a tool that allows the physician, the scientist, to introduce this additional copy of the beta globin gene inside the cells. And this is done by using a viral vector. In this case, we take advantage of the fact that lentiviruses, the HIV viruses, was very good in infecting cells, in particular hematopoietic stem cells. So now you have basically the envelope that looks like an HIV virus, but what is inside is the information to cure beta thalassemia, sickle cell anemia. And since the information that really stays in the cells after infection is basically the component that makes the beta globin gene, you don't really have an infection with an active HIV virus. For gene editing, the technologies evolved from a different kind of, from different studies, from knowledge, completely different knowledge. So this is called a CRISPR-Cas9 system, and it's basically a system to allows gene editing or gene modification of the DNA of the cells. You can basically, modifying the sequence of a gene. You can theoretically prevent that gene from functioning. And so they decided to do something very smart, which was basically there is a gene in all of us that makes a different kind of hemoglobin called fetal hemoglobin. So it's a kind of hemoglobin that we make when we are in utero, in the womb of our mothers. But then after birth there is a switching. So basically that gene that makes fetal hemoglobin is basically turned off, while the gene that makes adult hemoglobin, that's the beta globin gene, is turned on. And so people say, what if we basically, in patients that have sickle cell anemia and thalassemia, we can reverse that process. So now we basically reactivate the fetal hemoglobin gene, right? And automatically the expectation that the adult hemoglobin gene, the mutated beta globin gene will be switched off. And so people start thinking, so this is possible, right? There is a fetal hemoglobin gene available. Normally we don't use it. And there are actually few people walking around, they actually have this persistent expression of the fetal hemoglobin gene, and they do pretty well. So people start studying, by looking at, studying large population and try to identify when there were higher level of fetal hemoglobin expression in those few individuals, if there was any gene that could be associated with modification in this expression. And eventually they identified a gene called BCL11A. And so this gene is, I would say today, is probably the master regulator of fetal hemoglobin. Of course, there are other genes that collaborate and other genes that contribute to the expression of fetal hemoglobin. But this historically has been now probably the most studied gene that regulates fetal hemoglobin. And people realize that if you can block somehow the expression of that gene, you can reactivate fetal hemoglobin. So Casgevy, the product made by Casgevy, is basically taking the cells of the patients, introducing the CRISPR-Cas9 system, and you can target specific sequence in the DNA of the patient, and in this case the regions of the gene BCL11A that are important for its expression. And if you target those sequences, you can basically block the expression of the gene. And when the expression of the gene goes down, then fetal hemoglobin gene goes up.
I have one question first for leukemia. So, as you explained, it's a gene addition.
Mm-hmm.
So this happens randomly in the genome.
Correct.
So it could be inserted in a place that is, deleterious for the cell, and also it could be many copies that are inserted. What have you seen?
So the two systems are, I would say, still in their infancy, and we need to be aware there are limitations to these approaches. So if we focus on gene addition, it's true what you're saying. The integration of this gene with the current technology is pretty random. It's not completely random. People study and they realize that there are specific regions in the genome there, at least in the hematopoietic stem cells, that been a good target for this virus to land and introduce the gene. However, basically all the patients have been treated with this technology, except for a few exceptions. But all the patients at least treated for beta thalassemia, sickle cell anemia, they never had a problem. And so even if there's a relative random integration and the number of copies can change from one patient to another, none of them so far developed leukemia, which is obviously one of the concerns that people had at the beginning, especially because some of the initial studies were done with different kind of viruses. And now many patients have been treated and we didn't see that. There have been a few things, a couple patients that developed leukemia, for instance, in the patient population treated with leukemia, but they were not related to the integration of the vector. And people are still wondering why that happened. It may be that, the sickle cell population may have higher level of clonal hematopoiesis because the inflammatory milieu and background that they suffer all their life, and that leads to an increased rate of mutation that over time may lead to leukemia. The bone marrow transplantation is something that may increase the chances of leukemia as well. And this probably, if what I'm saying is correct, it doesn't make any difference if you treat the cells with a lentiviral vector or with a gene editing tool.
No.
Because if the patient with sickle cell anemia have a predisposition, I would say, to acquire mutation in the stem cells as they get older, this should only be the lenti versus the gene editing per se approach should not differentiate should not promote one or the other more, right? However, the gene editing approach is theoretically more focused on a single defined sequence in the genome of the patients. However, there are potentially side effects. For instance, this technology as it is right now from Casgevy is basically, it's really the first technology came out when CRISPR-Cas9 was utilized for gene therapy. So this is a technology basically creates a double-strand cat in the DNA. So you think about a chromosome, which is normally a long molecule of DNA, suddenly is divided in two parts. And now these two parts had to come back together, right? So, and this probably happens in majority of the cases, but you can imagine now that these two portion of the chromosome can start interacting with other region of the genome, and they may create instability in the genome, etc. So we don't know for sure if this technology is absolutely safer than the other technology. There are definitely pros and cons. I think we need to study them carefully, looking at long-term effects in the patients, and then decide if there is really a difference or not, and that eventually one is better than the other. We don't know what are the long-term effects of expressing high level of fetal hemoglobin, right? This is something that, as I said, there are few people express some level of fetal hemoglobin that benefit from having those levels instead of having the full disease, sickle cell or thalassemia. But the way we're increasing the fetal hemoglobin now is really to very maximum or very high level, especially in thalassemia where there is almost no competition. In sickle cell anemia, you create the fetal hemoglobin, but there is still some proportion of sickle which is diluting the fetal, right, somehow, right? Or the fetal is diluting the sickle, but altogether may be a good combination. In beta thalassemia, when you don't have a very low level of beta globin, you're expressing majority of fetal hemoglobin. So fetal hemoglobin is a hemoglobin that has a higher affinity for oxygen. So in other words, when you breathe oxygen, the hemoglobin is capturing oxygen in your lung, and as it goes around in your body, and basically releases oxygen based on the concentration of oxygen that decreases as you move from the lung to other organs. Now, with fetal hemoglobin, this oxygen affinity is higher, so we don't know how it's released, in our organs, and if there is any potential side effects in the long term. So there are a lot of things that right now we are learning, because we never had a situation, we couldn't really analyze people with this kind of artificial way of expressing genes, right? Which is curing many of them, but it's definitely a almost artificial, right? In a way. So it's a normal technology.
Why not to try to repair with CRISPR the endogenous mutation?
Absolutely. So the next step, I think, what people are trying to do now, instead of doing like the base editor came after, right? So the base editors are now basically fuse proteins. Basically, the Cas9 now is fused with additional proteins. They have the ability now to recognize a base and modify and revert that base, that mutation. That base is considered like, sickle cell anemia, there is a specific mutation. The idea is to go there and revert that mutation back to a sequence that now not harmful, right? And so this technology is considered obviously safer than just going there and opening the chromosome in two parts. So there is an evolution of all these things, and
It should be particularly easy in sickle cell disease.
it should be sickle cell, right, definitely. So there are no base editors that can revert the mutation of sickle cell mutation back to the original sequence, but people realize that there are in Indonesia there is an hemoglobin called Makassar, and that hemoglobin is completely normal, and it's different from the normal hemoglobin we make, but it's different in the sequence is different. The amino acid the amino acid sequence is different, but it works as well as the normal one. And so the people realize that with the current base editors, we can modify that mutation and make a sickle cell mutation, transform the sickle cell gene in a Makassar gene. And the Makassar gene, as I said, works well. So now people are trying to do that. So instead of using, again, targeting the gene, opening the chromosome in two parts, they're trying to use base editor to modify the sickle cell mutation in a Makassar sequence. But again, technology is evolving, and now basically we have potential prime editing system. Prime editing system is again an evolution of the CRISPR-Cas9 system. Again, it doesn't break the DNA in two parts, but is able basically to modify the sequence as you like. So then you can theoretically correct whatever mutation you want. It's not dependent on base editors anymore that are limiting what they can do. It's a technology. It's not efficient yet as the base editor technology, but I suspect that soon will be efficient enough to correct sickle cell mutation exactly as it is, as it should be, and so other mutation. But there are other technologies evolving as well. There's not just the prime editing, but there are different ways to modify the CRISPR-Cas9. Probably the TALEN technology, which is basically protein that can recognize a specific sequence in the DNA, can modify also to do base editing or maybe other things that the CRISPR-Cas9 system does now. So there are a lot of moving parts, but I think the most exciting part is really moving from this kind of technology, which is called ex vivo. You're probably familiar with that. So
yes.
So the key right now, I mean, the current approach is basically if you want to cure a patient with gene addition, with gene editing, you basically need to take the bone marrow cells out of the patient, right? This now is you can do this by mobilization, basically drugs that push the cells out of the bone marrow, go in circulation, and so you do something called apheresis, which means you collect the blood from these patients and then you select the stem cells are in circulation. Normally the stem cells are not in circulation, but you can give drug to the patient so that basically they go in circulation. And when you collect these cells, you put them in a petri dish, and now you do what you want to do. You do gene transfer with a lentiviral vector. You do base editing or CRISPR-Cas9, targeting BCL11A. But then you need to put back these cells into the patient bone marrow, right? And so I would say the mobilization and the collection of cells is relatively benign for the patient, but putting back this patient into the patient requires basically myeloablation. And myeloablation is still a very, very toxic procedures. So basically, you use chemicals that basically, in order to put these cells back, you need to make space in the bone marrow. I mean, simplifying, but basically, think about like, the bone marrow is full of these stem cells that have the mutation, and you want to put back now the stem cells that are corrected, right? But if you don't make space in the bone marrow, these stem cells will not home. They will not find a safe place where they can basically home and then proliferate. So you need to do something called myeloablation. Myeloablation is really giving
Therapy.
giving very toxic drugs to the patient to kill the bone marrow. But these drugs not only kill the bone marrow. One of the major side effects is most of the patient became infertile because these drugs also affect the germinal cells. And so think about a patient. Think about a family now. They have a kid with sickle cell anemia, beta-thalassemia, and maybe they do well in the sense, they're treated well, they go to a good hospital, they don't really have major problems. Of course, they need to get transfused, but they're thriving, they're growing, etc. And the patient and the parents and the kid are facing this dilemma. I'm doing okay, but I can cure my, there's now gene therapy. I can theoretically cure my disease, but I basically need to go through a myeloablation. So I think this is now the major roadblock, or the major negative aspect of these technologies, right? I mean, and when I say technologies, also even allogeneic bone marrow transplant, like getting the bone marrow from a donor, which is not gene therapy per se, it's a cellular therapy. But even in that case, you need to do myeloablation, right? And so these are really the major problems. And so people, including myself, are working on novel methods to create novel myeloablative regimens are not toxic, at least not as toxic as the one that they're given to the patient now, or doing vivo gene therapy, which is basically the idea of transferring this information directly to the bone marrow cells without like taking them out, do the myeloablation and putting them back, etc., etc. So if we can, in a stepwise fashion, maybe eliminate the major myeloablative toxicity first, and then eventually get to a point where we can do in vivo gene therapy, that would be very, very convenient for the patient, safer, and hopefully it's also cheaper. The technology to do in vivo gene therapy is pretty much the technology we're using for the COVID vaccine. So, those are relatively, it's a relatively cheaper technology. You don't need to bring the patient to the hospital for a long time. It doesn't, the patient doesn't become immunocompromised because the bone marrow, the myeloablation really eliminates the many cells in the white cells, etc. So they're prone to infection, etc. The idea to do in vivo gene therapy is really the goal is to infuse into the patient with 1 or 2 injections the product that will correct the stem cells, and come to goes to the clinic, gets in the injection and walks back the same day to go home.
So this is, you think, the future? That's what you're working on, to develop this kind of technology?
Yeah. I was very lucky. I'm a CHOP at Children's Hospital Philadelphia, but also I'm a faculty at the Penn University. And one of my colleagues is Drew Weissman, who won the Nobel Prize for the COVID vaccine because of a tremendous impact of his technology on saving millions of lives and simplifying also the way we can generate vaccine now. And so his technology basically is based on the fact that you can create these lipid nanoparticles, which are basically kind of like almost fat molecules, but they're made in a way that you can embed inside these molecules a piece of RNA, RNA sequence, which is basically information, right? And so the original technology was basically established to deliver RNA to trigger immune response against the
COVID.
the virus, COVID virus. And so a few years ago, I was talking with him, and we come out with the idea that maybe that technology, since we really, what you need to do in order to do gene editing to correct the cells, is really to deliver information so that these cells can correct the gene mutation, right? And so we already know that the base editor, for instance, are able to do so. And base editors are proteins, and they're a little component of RNA, but pretty much are proteins. But proteins can be made by the cells if you deliver the RNA that contains information to make the CRISPR, the base editor system, right? So we discussed how can we make the system expand this technology from doing vaccine to deliver inside the cells information that can theoretically correct the cells, right? And so so in the case of the vaccine, you inject your LNP lipid nanoparticles with RNA. It's an injection in your muscle, and that's where you basically create the immune response against a specific portion of the virus. In our case, we wanted to get to the bone marrow. And so first of all, you don't inject, if you inject that in the muscle, it wouldn't go in the right place. So you need to inject this in the blood, like so they can go in circulation. But after these lipid nanoparticles go in circulation, how do they know they need to transfer the information to the bone marrow and not to another organs, right? And so we decided to modify these lipid nanoparticles, something I call a GPS information, which basically is an antibody that was basically situated on the surface of these lipid nanoparticles. And this antibody has the function to recognize a specific receptor which is present in stem cells. And so these molecules go in circulation, but they don't necessarily stop everywhere, right? They just stop when they see there is a signal to tell them that's the right place. And so using this technology, we published a manuscript last year showing that's possible. Of course, we are talking about mice and not humans yet, but that really opened the gate to many investigations now. I mean, I think all the major biotechs are now investing in this technology because as a potential to be curative, not just for sickle cell disease, but for many diseases. And if you don't target the stem cell, you target the liver, you target other organs, you can now imagine how can you really correct many diseases.
So you did say that access is a big issue because the price at the moment of these gene therapies is really high. So you are now working on solutions to this. But for the moment, how many patients have received this therapy?
Well, I would say probably a couple hundred patients or even more. But I completely agree with you. It's a very expensive. It's a very expensive drug, right? Because it's not just a drug. It's not like when you generate this drug, it's not like a pill and then you give it to the patient. It's a procedure, right? So you need to make the virus, or you need to make the ingredients to do the CRISPR-Cas9. Then you need to bring to the patient the first time in the hospital to collect the bone marrow cells. Then you treat these bone marrow cells by one system or the other, and then you check if the stem cells are still stem cells, if they were treated well, if they used in a contaminated the stem cells, right? And you do all this testing. And then when the stem cells are ready, you bring the patient back, you do the immunoablation, and then infuse the stem cells. But then you need to wait several weeks, because after immunoablation, the patient is incompetent, right? So it can get any infection that can theoretically be lethal. And so you need to keep this patient in the hospital for several weeks. So you can imagine now we have several steps, right? So we need to make a virus. We need to be so-called GMP grade, good manufacturing practice. Technology need to be used to make this virus so that can be used in patient, and not like, I make the virus in the lab for mice, and, obviously it's challenging, but it's not as expensive, and, it doesn't require the level of production that is required for treating humans. And then there are all these additional procedures. So altogether, the product can be in the range of $2-3 million per patient, plus the expenses at the hospital, etc. So how do we fix this problem, right? Because it's a problem here in the United States, it's a problem in Europe, even if we are relatively in countries that can afford to pay some of this cost, but still it's very high, and not all the patient, especially in places where countries cannot afford that, or insurance don't allow the patient to get the therapy.
Yeah, especially
So-
that this sickle cell disease and thalassemia are more prevalent in countries that are
Exactly.
in
So
mid
yeah,
income or low income.
exactly. I was getting there, because if you can imagine how difficult it's maybe here. It's impossible in a country where there is no way they can spend $2-3 million to treat a patient. Despite the fact the majority of the patients with sickle cell anemia and thalassemia are not in the United States, are not in Europe, are in countries that cannot afford these therapies, right? So we need to start thinking about a different way to develop these therapies, and how to distribute them. I have a number of ideas. I hope one of them will be implemented by someone who has the power to do that. I have no companies. I'm making this as a scientist, and then people use this information to make drugs, etc. But if I had a company myself, first of all, depends on the technology, because if vivo and ex vivo, they're two different kind of technology. But let's focus on ex vivo. So first of all, I would say, well, we have intellectual property on this. I'm speaking as I'm the owner of the company, right? We have an intellectual property about this. First of all, how do we make this cheaper for the patients here? But the other thing I would do, I would say, let's talk with those countries where bringing the product there would be too expensive, and I would give my IP to them. They would invest in facilities to make these products, like maybe a non-profit organization, non-profit company, and I would try to teach them to do it, with help from organizations that want to bring these therapies to the patients, and help them, or help me also. And then I would say, okay, let's teach them how to do it in their place, having the facility to do it. That will be cheaper, right? And then provide this product to the patients. This actually is happening with vaccine. Drew Weissman is actually doing this. It's basically helping countries that otherwise wouldn't be able to buy even the vaccine, to create GMP facility in those countries. He talked with companies, and the companies help basically to transfer the technology to those countries where they wouldn't be able to sell the vaccine anyway, because they those people wouldn't have the money to buy from them. So basically, convince them to say, look, they need the vaccine. It's important. We cannot just cure people in this limited part of the planet. And so how do we do that? And so he basically was able to create these GMP facilities in those countries where they make their own vaccine, and with the support from these companies that provide them the technology, at least the knowledge to do it. Now they make vaccine in countries that otherwise wouldn't be able to provide vaccine to their population. So I think this to me, it's a very strong example of how ethically we should think about distributing technologies. And,
How to distribute better these technologies.
absolutely. And of course, if we think about now the next step, which is in vivo gene therapy, if we create this GMP facility that will make vaccine, the same facility theoretically can make the same tools similar tools to do in vivo gene therapy. So the technology is already there, and then we can implement that. And you don't need to be a bone marrow transplanter to cure this patient. You need to be a nurse that knows how to do an injection in those patients, so that you can basically correct their mutation.
All these technologies you are describing, how far are they from being really...
Well, I mean, I can speak for myself, and probably it's going to take a long time because I'm not supported by companies, and I don't have like a lot of resources. So I have like 3-4 people that are fantastic in my laboratory, but it's nothing compared to like 50 or 100 people working in companies with $1 million on their back. And if the company are going to make this technology available in a few years, I'm very happy. And my concern is that they really also think strongly how to make this technology that's curing a disease that's mostly prevalent in poor countries, how to make this technology available to those patients and children.
Yes, where it's needed the most, really. So there can be other genetic disorders also. If the technology is cheaper, there could be other genetic disorders that...
Absolutely. I mean, I think one of my goal is, I mean, I've been working on hemoglobinopathies because I knew about it. I come from Italy, and it's a country that still has a lot of patients with thalassemia, sickle cell anemia. But one of the things that I focus, and now we're talking about sickle cell anemia, but in my laboratory, we're at least 5-6 programs to treat other hematological disorders that are considered very rare, because I don't think company as right now they're interested. If we're talking about a few hundred patients, or even less, it's difficult to make a lot of money. But for me, providing tools that can help these patients, especially children, I work in a pediatric hospital. And if we get to the point that they're available, there must be at one point a conversation how we support these trials at the academic level, right? So if we don't want to do this through a company, which may not be interested, how do we support, the treatment of, my technology can be used by another hospital. We can transfer that as, as long as they don't make a profit, right? It's not, they don't act like a company. This can be done, this can be distributed to different centers. So if we have a few patients here, a few patients in another country, we can share this information. And the true also from other institutions, right? We have already a product to help this group of patients. We don't have to reinvent the wheel. We can help you to treat your patient in your country, and at the same time, with my technology, potentially we can treat those patients in those countries. So if we distribute this technology at the academic level with some support to do these trials, maybe we can convince you the insurance, to help this patient no matter what, because nobody else would do it, right? And maybe in Europe to have, and the cost would be lower, because doing it in the academic setting.
This is happening with CAR T therapies.
Yeah.
That the ones that are academically produced, obviously the price
They're
is cheaper. And
exactly.
Exactly. So there's some kind of proof of concept that this is possible from academia.
Right. Of course, the hospitals and academia, they need at least not to lose money, right? I mean, because otherwise it's going to be impossible. But at least to have some support to do it, right? And we need to define what is really the minimal amount of money required to do that. And of course, technology is evolving to a point where now the cost may be 10 and tomorrow's 9, and hopefully in a few years it's going to be 5, et cetera, right? And so, but I think we need to start having this conversation. How can we reimburse the academic institution to cure patients that otherwise would not be cured?
Well, thank you very much, Dr. Rivella, for this insightful conversation, for sharing all this valuable expertise with us. Thank you to all of you for listening. And if you like this episode, please share it with your colleagues and stay tuned for our next episodes. Thank you very much.
Thank you.